Good afternoon and welcome to today's Made by McGill Alumni webcast, COVID in Winter, How Concerned Should We Be? My name is Derek Kassoff, Managing Director of Communications at McGill's Office of University Advancement, and today is Wednesday, December 14th, 2022. As we brace for another winter under a cloud of COVID-19 and other seasonal viruses, what do we need to know to stay safe and sane? Will our hospitals be prepared to cope with a new influx of sick patients? Are there scenarios in which we might be facing yet another round of lockdowns and other public health restrictions? If these last 3 years have taught us anything, it's that there's not much we can count on with any certainty, except, of course, that McGill's leading medical and global health experts will deliver the information we need to know. And two of these experts, familiar faces to our regular viewers, are back with us today to walk us through this latest stage of the pandemic and answer your questions. Let me introduce them now. We have with us Dr. Marcel Behr, who's the director of MI4, the McGill Interdisciplinary Initiative in Infection and Immunity, and director of McGill's Infectious Diseases Division in the Faculty of Medicine and Health Sciences. Welcome, Dr. Behr.
Hi, Derek. Good to be back.
Great. And of course, we have with us Dr. Timothy Evans, who is director of McGill's School of Population and Global Health and executive director of Canada's COVID-19 Immunity Task Force. Welcome back as well, Dr. Evans, and thank you for joining us today.
Thanks for having me, Derek. Great to be back.
Great. So before we jump into the conversation today, a reminder that if you're watching live and you have questions for either of our panelists, you can send them to us by email at aoc@mcgill.ca, and we'll do our best to address them to our guests. So Dr. Evans, maybe I'll start with you. I think all of us remember that day back in March of 2020, when the head of the World Health Organization declared that COVID-19 was to be officially characterized as a pandemic. It was interesting that on that day, he said that the world had recorded 118,000 cases of COVID and that just over 4,000 people had died of the complications related to the virus. Numbers that seem fairly small when we look back on what the world has experienced these last 3 years. So my question is, where are we now in terms of the phases of the pandemic? And is there any hope that the WHO might soon be prepared to declare an end to the pandemic once and for all?
Yeah, well, Derek, first of all, I think we're so much further along in the pandemic that most of us have difficulty remembering back to March 2020. It seems not 32 months ago. It feels more like 32 years ago. And so I think the reality is living in the time of pandemic is one of accelerated aging for everybody because it's been exhausting on so many fronts. But we are really well into the 8th wave, which has been characterized by the way in which the pandemic has moved to being sort of revitalized through variants of the initial wild-type SARS-CoV-2 virus, and the latest variant being Omicron and subvariants of it. And the reality of Omicron is that it's much more transmissible and has escaped vaccine protection, and because of that immune escape and that transmissibility, there isn't any country in the world where there isn't widespread infection, and we've seen South Korea and China. And other areas in Asia, which were previously had very, very low infection and now no longer do. The Canadian situation is quite startling. We've been tracking infections since January 2021, and we estimate that 25 million Canadians have been infected since January. That's about 85,000 cases per day. Now, if you think of the peak number of cases of infection during previous waves, it was somewhere around 10 to 12,000 per day at the peak. The average every day during this year in Canada has been somewhere around 85,000 cases per day. So we estimate now that about 75% of Canadians have been infected, on top of very, very high vaccination coverage, particularly amongst adults and older people. There have been 50,000 deaths approximately to date, and very importantly, about 20,000 of those have been in the last year. So this surge in infections, even though it has been less severe in terms of the symptoms and the severe illness, because there have been so many cases, we've seen 20,000 more deaths this year, and that translates to about 50 deaths per day, and that would place it as the third leading cause of death in Canada. So those are some of the realities in terms of where we are. WHO has been toying with the idea about how to call the pandemic to an end, but the criteria to do that are lacking. There's not clarity that we've achieved population immunity. That's the combination of infection and vaccine-acquired immunity that would really stop transmission. We're still seeing serious morbidity and mortality in many places, and so it's not clear that on the clinical presentation that we're at a point in which we could say the pandemic is over. Having said that, as we've seen in our own jurisdictions in Canada, provinces and territories, the politicians, I think largely in response to the public, have called the pandemic over. And this is why public health measures have gone out of style, which unfortunately, as Marcel will say more, is putting a lot of pressure on hospitals at the moment. So I think that's where we are.
Wow, this is already shaping up to be scarier than my last webcast last month on spiders. So, but at least you came prepared with some very sobering statistics. I have a bunch of follow-up questions to that, but let me bring in Dr. Behr before I get back to sort of the who and what of the virus itself and the pandemic. So, Dr. Behr, can you describe for us or provide us with a bit of an update on the current situation in our hospitals? I know at the MUHC where you're based, but perhaps even elsewhere in Quebec and Canada. What is the hospital situation looking like right now?
So thanks, Derek, and thanks, Tim, for setting the stage with all those numbers. So right now, the inside the hospital, we do wear masks, and we still treat this as if we're part of this sort of pandemic era, and we still have limited interactions among staff. So we haven't completely turned off the way that some politicians have said, oh, it's over, it's done. But that said, if you were to look in the hospital right now and say how many people have been admitted with COVID and how many people have been admitted with the flu, we may have more people with the flu who have been admitted at the present than with COVID. So we still do have COVID patients, but we have high coverage of vaccination, especially in the immune-compromised people, and we have treatments, and we have ways to preemptively treat people when their PCR is positive before they get sick, and we have treatments to offer to people when they get sick. So right now, in terms of the burden of beds in the hospital that is controlled or dominated by COVID, it's not like it was in April, May of 2020. So that's good news. On the other hand, because there is COVID, flu, and RSV, if you talk to my colleagues in pediatrics, they'll tell you that this triple epidemic has overwhelmed their emergency room and their ICU. So some of the lessons from COVID are reminding us that other respiratory viruses happen, and other respiratory viruses also can wreak havoc. And maybe we were ignoring them for too long before 2020.
So before I jump back on to that point on the other respiratory illnesses, can I just ask you, Dr. Behr, to talk about the children's hospitals in particular? Because I know you mentioned RSV, which seems to be afflicting younger patients much more seriously. Is there still a big concern about overcapacity at the children's hospitals, both here in Quebec and elsewhere in the country?
Yeah, I think there's several layers to this surge of demand. And the question is, what is the medical system supplying? I think people have a sick child at home. They want to go to a drop-in clinic or a walk-in clinic. Walk-in clinics are not working, to my understanding, at the same level as they were 10 years ago. Some doctors have been working in Zoom, so you've got telehealth, but you've got a sick child. Do you want to see somebody on telehealth, or do you want to see a doctor? So this leads to more people going to the emergency room for things that they wouldn't have previously gone to the emergency room for. And then you have the issue about whether the pharmacies have the cold medicines or not, and things like that. So there's this incredible demand being placed on the Montreal Children's Emergency, and you're reading the same thing from other hospitals in Canada. And then, of course, some of these children have to be admitted, and some of the ones have to be admitted are severely ill, and then the ICUs are full. So there is a tremendous tax really right now, or demand on the children's hospitals across Canada from the three viruses. It's not uniquely due to COVID. And my colleagues are understandably frustrated. My colleagues in pediatric infectious diseases are doing very long days, and they can't believe how many cases they're seeing.
Wow. So it certainly sounds like we're not out of the woods by any means at all. So Dr. Evans, I know Dr. Behr mentioned sort of this sort of notion of this triple pandemic that we've heard so much about: COVID-19, RSV, particularly among young children, seasonal flu now sort of roaring back. So how worried, as a global health expert, if I can ask you, should we be about this so-called triple threat? And how much of the spike in respiratory illnesses beyond COVID do you think might be attributed to the fact that our immune systems have largely gone untested during so many months of lockdowns and physical distancing?
So I think it's a great question. And the very short answer is that we don't really know why. But I think there's a very reasonable hypothesis that with 2 years during which we had really very strong public health measures related to lockdowns that canceled public events and closed restaurants, people working from home, and no school, masks being worn, physical distancing, all of those things really limited exposure of children in particular to those seasonal respiratory viruses that typically they get exposed to if you don't have those extraordinary measures. And correspondingly, we saw very low levels of influenza and RSV transmission in 2020 and 2021. And so we're really seeing now a situation where children of all ages were really not exposed. Therefore, they didn't really either reinforce or build their immunity. Young children who were born during that time didn't get maternal antibodies through breastfeeding, which would have given them protection from those viruses. So I think the idea that these measures may have inadvertently created a situation where these children's immune systems were more vulnerable to these seasonal respiratory viruses is a reasonable hypothesis. And I think when we opened up, as we have in September, back to school, no masks, no public health measures, with children who hadn't been exposed, and also recognizing that children have the lowest rates of vaccination for COVID. Children under 5, it's less than 5% of children and under 5 have a full 2 doses of the vaccine. So I think those are the conditions in which we're seeing this so-called triple threat or triple set of 3 viruses that are causing this huge surge and massive challenges on an already tired and overtaxed health system.
Great. Well, thank you for the response on that. Dr. Behr, do you take any solace in the fact that, that at least we could maybe point to the fact that the death rates, the fatality rates among, COVID, those infected with COVID seems to be lower? Is that a good sign? Is that perhaps leading to too much complacency? And I guess my second question is, why are we seeing that? Is it because the vaccines are in fact working and blunting the ferocity of the virus, or we just become better as medical practitioners in treating those who have become ill?
So Derek, I think you asked me, is it a good sign or can it lead to complacency? And if I understand, it can be both a good sign and something that can lead to complacency. So let's just remember that there's 2 types of things you want to do in public health. One is you may want to prevent a virus from spreading, and another is you may want to prevent people from getting sick. And some of the messaging around vaccines and prior infection was the idea that if you were vaccinated, maybe you wouldn't get infected again, or maybe you wouldn't be able to spread again. And as Tim has already mentioned, with things like Omicron, we don't have that luxury. We can't say that the vaccines have prevented Omicron from spreading around all around the world. But what the vaccines were licensed to do, if you read the original studies, is to keep people out of the ICU and to die less. And they are fantastically good at preventing individual morbidity or individual harm, even if they are perhaps mediocre at preventing transmission. So that's the good news. And as Tim also mentioned, about 75% of Canadians have prior infection. So they also have memory from natural infection. So if you now multiply the amount of people who've been vaccinated times the proportion of people who've been infected before, you have a lot of people with hybrid immunity. So on the good news, we do have a situation where the mortality rate is down because a lot of people have some form of protection against severe disease. Can that lead to complacency? Of course it can, because people can say, oh, well, COVID is nothing, it's no big deal anymore. But as long as it's spreading, the few people who are either unvaccinated, and I have encountered some unvaccinated people recently, if they get infected, they can still have the same COVID as April 2020. And the people who are immune compromised, who may have taken 3 or 4 vaccines, but their body just can't mount immune response, these people are still vulnerable and at risk.
Okay, so let me ask you both this question. Do either of you envision a scenario whereby governments might need to reimpose certain public health restrictions on their populations, perhaps more masking or perhaps even lockdowns? Or do you think we're at a point where the politicians realize that the populations are just so fed up that they would be unwilling to accept or adhere to any restrictions, 3 years into this pandemic?
I'm going to let Tim answer this question.
Thanks for the easy one, Marcel. There are other questions to come. Watch out. I think the thing about this pandemic, which has been so humbling, is that every time we thought we knew what the future might look like, we struck out. The COVID pandemic picture throws incredibly good spitballs and curveballs. And so I would be very cautious. A year ago, late November, I think a lot of us thought things were winding down until we heard about Omicron. And even when we heard about Omicron, people thought, it's mild, it's not going to make a difference. But so many people got infected. As I mentioned earlier, Eric, 20,000 deaths, third leading cause of death in Canada, is nothing to suggest, even if the rates of mortality are low, those are large numbers of people dying in our country. And so as a politician, as a healthcare professional, you can't ignore that. And so I think we need to be vigilant. And if we do see a new variant that is perhaps causing more sickness, breaking through immunity, which is getting stronger and stronger because of infection and vaccines. But if we do, then I think more severe or more aggressive public health measures shouldn't be ruled out. However, I think the sentiment of the politicians and the public are such at the moment that we're really going to have to see strong evidence of that. And at the moment, even though we're getting slammed in emergency rooms with children due to this triple threat, it doesn't seem like that's sufficient to change the recommendations on public health measures. So my sense is at the moment, unlikely that we're going to see a change in the messages coming from our politicians.
I'd just like to reiterate that in the worst of the lockdowns and the curfews, we had to go to bed at 8 o'clock. And those of us, Tim and I, who go cross-country skiing on Mount Royal, would really not like to see those kind of curfews in the evening. It's a fantastic place to be. We're going to have a big snowstorm on Friday. And hopefully, if there are measures brought in, they will not restrict people from doing outdoor activities, because one of the things we've learned over the past few years is that super spreading activities in parks and outdoors are really quite rare. And I would not want to have those kind of curfews again.
Okay, great. Well, thank you. Thank you both for that great advice and a weather forecast, Dr. Behr. Yes, a lot of snow on the way for us here in Montreal, at least. Just a reminder, if you're watching and you have any questions for either Dr. Evans or Dr. Behr, you could send them to us by email at aoc@mcgill.ca. So, Dr. Behr, from a personal level, personal perspective, what would you suggest someone who's still obviously concerned about COVID do to keep themselves protected in this world of essentially no more public health restrictions?
Well, of course, as people in the lab remind me, people aren't all twins. We aren't all the same. We're young and old, and we have different immune systems. So each person needs to gauge what their risk is depending on what conditions, diseases they have, what risk factors they have. So what do? I've decided pragmatically to follow the guidelines on most occasions, because if I deviate from the guidelines and something bad happens, it's my fault. But if I follow the guidelines and something unfortunate happens, I can at least blame the government for my weakness. So I've had 4 vaccines. And when I'm ready for my next one, I will have one. And earlier this week, I got my flu vaccine. So these are the actionable things you can do. You consult the vaccine schedule and you get vaccinated when it's available. One thing I would really like to do, and I talked with Tim earlier about it, and it's not so easy to do, but I'd like to get a little bit more variety into my vaccine life. I might want to have one of the vaccines that's being given in other parts of the world and send our mRNA vaccines over, so there would be a giant swap of vaccines. I think would be good for my immune system to have more variety. But for now, I take the vaccine that's offered to me. I wear a mask in the hospital, and I generally wear a mask in the bus and in crowded places. Partly as a courtesy to the other people. The people who are working there might be worried about whether I'm bringing virus. And so, but that's a personal choice. I don't think we're going to have signs at the door saying you must do so. We just got an email from our dean yesterday reinforcing what the mask guidance is on campus. But then again, that's a guidance and it's not a mandate or not a law. And I think what we can do is just try to be responsible about what our own risks are. But I don't think I can say that there's a standard answer for everybody, because the answer to somebody who is a caretaker of somebody in a senior residence may be very different than the answer to somebody who's got children in an elementary school.
Okay, fair enough. So, Dr. Evans, maybe I can ask you, you obviously came well prepared today with lots of statistics and data representative of the Canadian population and how it's been sort of coping or dealing with COVID. Can you provide us with an update on the work of Canada's COVID-19 Immunity Task Force, and what sort of work is the task force currently engaged with? I guess compiling a lot of these statistics is part of the work, if I'm not mistaken.
Yeah, well, thanks, Derek. And yeah, when we started the task force in April of 2020, I think most of us thought it would be done and dusted by this time. And unfortunately, we're into double overtime. We're really busier than ever. What happened at this time last year is that the acute infection testing with PCR got overwhelmed by the Omicron tsunami. And so the only way we could actually track the magnitude and trends of the pandemic was by looking for infection in blood, past infection with antibodies, drawing on blood banks and residual bloods and surveys that the task force, the COVID Immunity Task Force, has been undertaking. So we've been doing bi-weekly or twice a month reports to the Chief Public Health Officer of Canada, tracking the Omicron tsunami and the various waves that have come after it. That's where we've been really able to look at, come up with the data that nearly 75% of Canadians now have been infected, that 25 million Canadians have been infected since January 1, 2022. We've also been able to piece together the big picture of immunity. And Marcel mentioned this a little bit, but we've looked at this with some data, and very, very few Canadians have neither had a vaccine or are infected. Less than 1 million. We have about 2 to 3 million who have only been infected, i.e., not vaccinated. And then we have about 12 million Canadians that have not had an infection, but have been vaccinated. Okay, and most of those are older Canadians. And that's a great sign because they're most vulnerable. And if they can get all of their immunity through vaccines, that's much better than getting it through infection. But the largest and growing group, fastest growing group, are those that have both had vaccines and have been infected once, maybe twice. And that is now about 22 million Canadians. Okay, so that's the majority of Canadians, and it continues to grow. And this is what Dr. Behr mentioned is a hybrid immunity. And the studies that have been done on that suggest that, in fact, this is provides you with a very strong protection from symptoms and illness once you've been both infected and had vaccines. So that's been the big bulk of our work. A couple of other areas that are really important has been to look at children in particular, because they were the last to get the vaccine rolled out to them. And as I mentioned earlier, the coverage of the vaccines in children under the age of 12 has been very low. And so this is contrasting very much with the older population. We've got less than 50% of children under 12 and less than 5% of children under 5 that have had a full vaccination, full series. So understanding their immune trajectory and the protection in that population, we have a bunch of studies ongoing. The last thing, we will be coming to a close at some point in the near future, we hope. And one of the things that we've been doing is we've been looking at trying to understand how we can prepare better for the future. And I think there's a whole exercise that the task force is engaged in, which is trying to learn from our experience such that should we face another pandemic, we'll be able to move the infrastructure to understand the situation with respect to immunity much better, much faster, and more reliably in the future. So we're looking at that and trying to pull that together in the next few months.
Okay, great. Just a quick follow-up question. Are the cities still testing for COVID in wastewater? I know that was an effective, I guess, measure early on to sort of see the spread. Is that still happening?
Yes, it is, and in fact, this is one of the what I'd call a bright spot in terms of some of the learning, and it relates to the fact that the technical capacity to look and find virus and assess concentrations of virus and sequence that virus to understand what variants might be in the wastewater. That has evolved in such a way that it's become very useful public health knowledge and is associated and is accessible in such a way that it can give an indication of whether the pandemic is getting worse or perhaps getting better. So this is, I think, really, really important. Wastewater can be looked at not only for SARS-CoV-2, it can be looked at for all sorts of different things. And so I think this is going to become a mainstay of our public health surveillance, just like blood banks and others, into the future.
Wow, interesting.
Yeah, I'd just like to reiterate, so Dominique Frigault, who has led some of the wastewater work here at McGill University, says that wastewater is information. And I think that's a really key way to conceptualize it. And there's lots of information in there.
Wow, sounds interesting. But didn't they do this even back in like the 19th century in the UK? You hear stories about plagues, and I think even back then were they not using wastewater as a way to, or maybe they just didn't have the technology to do it back then.
Well, I think the John Snow work was likely related, where he said, if the water in your tap had more salt in it, you're more likely to get cholera than if the water in your tap was clean. So that meant that your tap was coming from downstream of London rather than upstream of London. So the amount of chloride there was a proxy that it was contaminated with things, but he wasn't exactly measuring what was there because his work was done before the agent of cholera was discovered.
Right. Interesting. Okay. So as you both might imagine, we're getting a ton of questions coming in from alumni. So I do want to move to them fairly soon. I imagine more will continue to come in. But maybe before we do that, a couple of final questions on my end. So Dr. Evans, I wonder if you could talk about maybe some of the positive developments that have emerged around COVID and vaccine developments, particularly in the emergent area of mRNA technologies. So I know earlier this year, McGill became the first Canadian university to join Moderna's mRNA access platform, which I understand is hoping to bring mRNA-based vaccines and medicines to the fight against other infectious diseases and illnesses, and perhaps even certain cancers. Can you talk a little bit about what this partnership looks like and what these possibilities might mean to global and human health?
Yeah, I'll just say a few things, and I think Marcel can come in with some specifics related to folks that are taking advantage of this platform. But first of all, I think it is an enormously positive signal in terms that we're going to come out of this pandemic better in better shape than we entered. And the reason I say that is that those of us who've been in the pandemic trenches for a long time, like me, have always pointed to the need to get the research and development of new vaccines, drugs, and diagnostics into gear or into a situation where it can be ramped up quickly in the context of a crisis. And I think having this sort of platform at McGill means that the academic environment where you've got all of that basic research going on is going to be continuously primed to be thinking about how to develop new products for potentially infectious pathogens. When I was at the World Bank, we set up something called the Coalition for Epidemic Preparedness and Innovation, CEPI, and the whole principle behind that coalition was to make sure there were a set of pathogens where there was active research going on so that candidates for vaccines or therapeutics could get into clinical trials very rapidly if there was an outbreak of that pathogen, for example, Ebola. So that I think is really, really important. But I think more fundamentally, this represents a change in the way we think about research and development for the world. And that is that we're gearing our industry in research and development to make sure it caters to 7 billion people. Not just a billion rich people who can pay a high price, but 7 billion. And if we can shrink the time to develop a vaccine, as we have in the context of this pandemic, and if we can recognize that the market value of 7 billion citizens is much greater than 1 billion, then I think we're really changing the paradigm of R&D in such a way that we're all going to have a much more secure future with respect to infectious pathogens. So I see this as part of a much bigger change, and I'm delighted that McGill is partnering with Moderna on this.
Well, there's a positive. Dr. Behr, you want to jump in?
Sure. So I think there's two really interesting advances here. One is the capacity to adapt this technology to different pathogens and scale. And the other is the understanding of the disease and what protective immunity looks like. So regarding the technical capacity, if it works for SARS-CoV-2, we can envision a world where it works for other viruses a pan-coronavirus or an avian flu virus or RSV virus. And there's all kinds of research opportunities here, but also to extend to bacterial infections. We have epidemic rates of Haemophilus influenza A in certain parts of Canada, and maybe even to parasitic diseases. And a colleague of mine, Momar Ndao, is working on cryptosporidium and schistosomiasis diseases, which until now have been largely considered non-vaccine preventable. The other arm of it is going to take a little bit more time, but we've already seen that loop pretty much close with SARS-CoV-2. Earlier this week, there was a New England Journal article that said that we not only have vaccines that prevent going to the ICU and dying, but we have a blood test that can tell you. It's called a correlate of immunity. And having a correlate of immunity enables us to say, okay, how does certain changes and tweaks and alterations affect the antibodies that we make? And we don't always have to go back and do huge randomized controlled trials and leave people in the placebo group if we know what it is we want our vaccine to do. The challenge here is to know what the correlate of immunity will be for RSV, or the correlate of immunity will be for cryptosporidium or schistosomiasis. And there will be more research ahead. We can't simply say the blood test we do on people that correlates with protection in SARS-CoV-2 will automatically translate into the blood test that correlates with immunity in schistosomiasis. But at least we now have a platform to make the vaccines and start to look at this.
Mm-hmm. Okay, wonderful. Thank you both for that very thoughtful and I guess a very optimistic response to that question. I have so many more questions for each of you, but let me move to some of the alumni questions. Like I said, we're receiving quite a few, so I'll get to some of them. I'll start with this first one. This one actually came into us from Dan Goodwill, and he sent it in about a week ago, so you'll recognize that things have changed on the ground with this. But he writes, there's a concern that as a result of the protests in various cities in China, the government of China may ease its zero COVID policy. And in fact, we've seen since then that they have done so. Since the made in China vaccines are believed to be less effective than the mRNA vaccines, could Chinese citizens traveling to Canada trigger an outbreak of COVID in this country? Would you please comment on the likelihood of this possibility?
I'll jump in and Marcel can correct me. But I would say low likelihood, and a couple reasons. First, I think the evidence that the vaccines in China are less effective with respect to severe consequences of disease is not overwhelming, and I don't think is really the relevant issue in the context of China. I think the reality is that in China, vaccine distribution internally was not a priority, especially amongst elderly people. And so I think that's where in the pre-Omicron era, where you could really test and trace and keep the pandemic under control, you could afford not to worry about vaccination because they had one or two cases a day. In the Omicron era, test and contain strategies don't work, and I think China has realized this. The reason I don't think anybody traveling to Canada is a threat is it's part of the reason why they've removed the ArriveCan app, etc. If you look at the extent to which we have layers of protection now in Canada with very, very high rates of vaccination, multiple vaccinations, plus infection, the so-called hybrid immunity, then it's very unlikely that someone coming from China is going to constitute what I would call a threat to an outbreak of COVID at this time. So that would be my view. I'd say very unlikely.
Okay, great.
Yeah, my understanding is the vaccine rates are quite low in the elderly in China. So the idea that a number of elderly Chinese people would fly to Montreal or Vancouver to get vaccinated just seems kind of an implausible scenario. And, it's easy to say our vaccine is better than their vaccine, but I agree with Tim that if there's a vaccine in China and low uptake, the immediate actionable thing is to increase distribution of vaccine in the country that has the vaccine.
Okay, great, fair enough, and thank you, Dan, for that question. So here's another one that came in. It's a bit long, but charming in part. So I'll read most of it. It came to us from Jeff Gifford, BCom85. He says, "I've really enjoyed the previous sessions you've presented along with Dr. Behr and Dr. Evans. You're a great team." So we'll take that. But there's more. In any event, I was wondering if this question could be asked. My wife and I have had 5 COVID-19 shots each as of mid-November, and have always been diligent in wearing our masks where appropriate. We have thankfully been healthy since COVID became a household word. This anecdote may serve as a learning opportunity for others who will be having family visiting over the upcoming holidays from the States or other countries. Our relatives recently drove from California to our house in Ontario. Long story short, soon after their arrival in early December, everyone started feeling unwell, and lo and behold, we all tested positive for COVID. We did not wear masks when they initially entered their house, as we did not suspect anything would happen. Our relatives are staying for another month. The question is, should we all be continuing to mask until all 4 of us are testing negative? Or is it acceptable for us all to go maskless now that we are all COVID-19 positive, and just let the virus run its course?
I guess it's nice to hear great feedback, and it's also nice to hear about people who are courageous enough to have family over for more than 72 hours. I thought that was the incubation period at which frustration and dissent usually happens. It sounds like if there's basically a bubble of people who are all staying in the same home and they all had COVID upon arrival, they should just go out and enjoy the next month and do things together. The extent to which they'll be interacting with more and more people, of course, gets it much more complicated. But it sounds like what I've heard is people are vaccinated and they've tested positive. I did not hear that people are getting severely ill. And this reminds us again of the immunity information that Tim provided before. The vaccines and prior infection have done a fantastic job of preventing people from getting severely ill. And if that's what they are doing, then that's really good news to hear. So the alternative, of course, is to not see your family for years after years, and that's going to be very difficult to do.
Mm-hmm. Although there could be some positives. No.
The one thing I might add to that is that insofar as they're still symptomatic or testing positive, I think outside the house, wearing masks would be considerate in order to prevent spread. But inside the house, obviously they're all infected already, so I don't think the masks are going to provide any benefit unless they have visitors, in which case, wearing masks would be appropriate, and also letting those visitors know that they have tested positive.
Okay, great. Well, thank you both. And thank you, Jeff, for the question and for the kind words to all of us. Much appreciated. Again, if you have any questions for our panelists, you can send them to us by email at aoc@mcgill.ca. Here's one, I guess, on the same sort of similar vein from Peter Stricker. What is the recommendation of the experts for precautions we can take when visiting our 9-month-old grandson? We are fully vaccinated.
I don't know if there's any new precautions. I mean, 9-month-old children can have any one of many things, and they're more likely to have RSV when I trained. If they're concerned about giving something to the grandchild, they can do a self-test before going, and they can wear a mask to protect others. And if they're concerned that the 9-month-old is bubbling up little raspberries and things like that, they can also consider masking themselves to not get infected from the child. I'd have great difficulty putting that child away from the family and the caring environment that the 9-month-old child deserves. So I think the only thing the adults can do is self-test and mask if they're concerned.
Okay, great.
And be vaccinated, of course.
Right. Sounds like they are in this case. So, all right. The next question, maybe I'll flip this one to you, Dr. Evans. It's from Diane Phillips. Do we have any statistics on who or how many have long COVID? Is there less of it with more people being vaccinated, and any new information on how to treat it?
Great. Well, thanks. And this very, very good question. The long COVID, or what some people call post-COVID condition, is an assemblage of symptoms that appear to be more common in people that have been infected following, or people following a COVID infection for more than 3 months after the infection. It's very tricky to pin it down more precisely. And just to say, this is a very broad set of symptoms that increased heart rate, variations in your blood pressure, brain fog, difficulty with executive function, all sorts of things that are tough to sort of describe as a singular entity. However, the association with infection it seems to be real. And there are some studies that suggest if you've been vaccinated, that you seem to suffer less frequently from these symptoms, these post-COVID or long COVID symptoms. There's a huge amount of work going on at the moment, which is focusing on different ways in which you can address the challenge of long COVID, from understanding why it's arising in the first place to trying to treat different parts of the symptoms, including, for example, rehabilitation efforts to get people back to work. So there's a big spectrum of things that are being tested. There's some initial, very, very early results that suggest that there are some things that help, but there's not any pill that I'm aware of that is being recommended as something that takes care of something called long COVID at the moment. I think it's going to have all sorts of different healthcare professionals helping to address and hopefully resolve some of those symptoms as quickly as possible for those who are suffering.
Okay, great.
Just following up on Tim's point that there isn't a single pill for long COVID or for post-COVID condition. I can tell you one of my jobs is I am a laboratory medicine specialist. So what we do is we offer tests, and we offer SARS-CoV-2 tests or tuberculosis tests or other things. And we have to recognize that the medical community is not very good in understanding the biology and the epidemiology and the treatment of conditions for which there isn't a test. Now, that reminds us that there are conditions that we really all know very well that don't have a test. If you eat ice cream very fast, you'll get a headache. But there will be no blood test that I could administer on you that says you have a headache. And the absence of that blood test does not deny that you have a headache. You clearly have a headache, and we don't have a test for it. And so people who have the symptoms that Tim has been describing may have one condition or 3 conditions or 5 conditions. It could be heterogeneous. But until we have some reliable tests for it, it's been very difficult to pin down some of the important aspects that could be actionable and could lead to specific interventions that these people need.
Great. All right. Well, thank you both for that answer. So let me move on to some other ones. Like I said, we've got quite a few, so I'll throw them out and we'll maybe try to keep the answers a bit quick if we can. This one comes from Susan Marcel. Speaking of tests, she says that tests exist to measure our level of antibodies. Should these tests be offered to the population?
In most cases, you don't need to know. Or for instance, I have never wanted to go to Jean Coutu and find out my neutralizing antibody titer. I don't see that as actionable for me. On the other hand, there are certain cases where somebody who has a kidney transplant comes in and they have SARS-CoV-2 and we're trying to eliminate it and the drugs aren't working. And then we'd say, well, if we have this result, this will guide us down one path or another path. So the test should be available for the healthcare system to help guide very particular medical questions, but they are not necessary at a population level, in my opinion.
Okay.
Yeah, so just I think to reinforce a little bit what Marcel is saying is that we've learned a tremendous amount about the magnitude and trends related to the pandemic by looking at antibodies produced following infection and also arising from vaccination. And that gives us a sense of the big picture of immunity in the population as we've described. I think when it comes to tailoring individual care or the need for a next booster, we're still in search of what I call the holy grail of a very reliable correlative protection. And the New England Journal article that Marcel mentioned is perhaps pointing us in that direction. But we're certainly not at the stage yet where we can measure those to a point to say, actually, your correlative protection is so low or immeasurable that you need to get boosted. It may be in the next, with a little bit more research, that we get to that point. And if we could, that could perhaps be a great breakthrough because we might begin recommending boosters on the basis of your own immune profile rather than what we think is best for broad swaths of the population. We're not there yet, but I think we're not too far off, and I'm hoping we can get there with more hard work from Marcel.
Well, if we wouldn't waste so much of his time in bringing him back on these webcasts, he can get to some of the real work. But all right, here's a question from Suzanne King. So following up, I guess, on our conversation earlier about wastewater, she's wondering if the monitoring of wastewater, does monitoring of wastewater concord with other indices of population infection?
So the answer is generally yes. So if you look at the presentations by Dominique Fligon and other groups and groups of Elizabeth Edwards in Toronto and others, when you see surges of infections in a community, you often see surges of the amount of SARS-CoV-2 RNA in wastewater. Whether they're mapping perfectly on a day-to-day basis or it's happening 3 days later or 3 days earlier, that depends on all kinds of engineering things. And I've only learned recently that Montreal blends together its rainwater and its toilet water. So you have to understand details of engineering and how wastewater is processed to map it to individual cities. So there's a correlation, but you have to understand where is the water coming in, where's the water going out for each city to interpret it the best. And that's why a lot of this work is being done by engineers.
Makes sense. All right. Here's a question from Carrie Mazoff. Oh, hey, Carrie. I know Carrie. She's asking, what do we know about the current bivalent vaccine available for protection against the most recent virus? Would you still recommend this vaccine as a booster, even with prior infection?
I honestly can't keep up with every single vaccine that's coming along, and maybe Tim has the answer to me. I do what Click Santé tells me to do, and I follow the guidelines in my place. I just want to have variety if possible. So if I'm offered a choice between something new and something old, I'll take something new. But whether we all need the bivalent or not, these things are a moving target, and you know, we're going to be looking at new vaccines in 2023, I'm sure.
I just reinforce what Marcel is saying. I think what's more important is to look at the time from your last vaccination and knowing your own health status. But if you're more than 6 months from your last vaccination, then you should be looking at getting a booster. If you have multiple health conditions that might make you more susceptible to severe effects, you should be perhaps more vigilant in terms of looking at boosts. But I would say that you should take what's ever available, and we'll see new vaccines, I'm sure, on the horizon coming forward.
Okay, great. All right. Let's go to this question from Karen Scortino. She's asking if there's any emerging evidence that the level of immunity to COVID-19 might be qualified depending on which variant one was infected with, or the number or kinds of boosters a person had following their original vaccination.
So we're all going to have different trajectories. Some people have been vaccinated before they were infected. Other people will be infected before they were vaccinated. And some people will have had the original virus or the beta or the delta. I'm sure there will be correlations, that there will be slight differences in that story. But the real question is, will this lead to a completely different answer, that there was the protective combination and the useless combination? And I'm not aware of any data that says there is a useless combination and this is going to lock you into futility. There has been a lot of discussion about this with influenza, and they use this sort of biblical term called original antigenic sin, and that original sin could affect how you respond in the future. I'm not aware that there's anything in SARS-CoV-2 that is pointing to an original sin.
Mm-hmm.
Yeah, I don't want to make this personal with respect to Marcel and his sins, but I think that this is actually a very good question. The Immunity Task Force that I've been running has actually designed studies to get insights on this. None of those studies have produced results to date. And part of the challenge is that the situation has changed frequently over the last year and a half in terms of the variant that we've been looking at, and also the vaccines that were available, and the combinations of the vaccines, the numbers of the vaccines. So it's meant not to suggest excuses for research, but protocols get designed at a state and time, and it's tough to change them because circumstances change afterwards, because there's all sorts of ethics boards that things have to go through. So just to say, excellent question, very tough for us to generate evidence on it, although we have been trying.
Mm-hmm. Okay, great. So I guess we have time for maybe one more question, and I'm sorry we're not going to be able to get to many more that have come in. Here's hopefully a simple one. This came to us from Michael Korber. He's asking if the doctors have any advice regarding air or train travel this season.
Tim?
Yeah, well, I think it's a function of where you're going, of what you want to do with your life. I would say if you're in air and trains, if you're concerned about infection, you should wear a mask. And it's a closed-in space, and there's tons of virus out there, not only SARS-CoV-2, but a lot of influenza and other viruses. So I think if you want to avoid infection, you should wear a mask. If you're in any way symptomatic, you should also wear a mask. So I would suggest, if you're thinking about travel, certainly go ahead, but protect yourself and protect others.
And if you're going to wear a mask in the plane or in the train, you should also wear it in the terminal, because there's very crowded waiting rooms, and the waiting rooms could even be poorly ventilated compared to the airplane itself. So don't just snap it on when you get on the plane.
Very good advice. And if I can add, I've gone on 2 air trips in the last couple of weeks, and I can definitely recommend take the train. but that's a whole other webcast there. Anyways, I see we're just about at the top of the hour, and that
Derek, did you take that transatlantic train?
The trans no.
Okay.
No.
Okay.
Short trips that could have gotten me over the Atlantic when it realized how long it took me to get home in one particular case. But anyway, yeah. Anyways, but listen, thank you. That just about wraps up the time we do have today. Before we close, I'd like to remind you that this video will be available at this very same link soon after our recording ends. So feel free to share it with others who may not have been able to tune in live today. I would, of course, like to extend my deepest gratitude to our 2 panelists, guests, Doctors Tim Evans and Marcel Behr, for joining me again today and offering their usual mix of terrific information and pretty okay humor at times. And again, thank you to everyone for tuning in, and so many of you who sent in questions, some of which we were able to address to the doctors today. Please stay tuned to your McGill email and social media feeds for more updates on our alumni programming in 2023. It sounds like we'll definitely have to have both of you back again at some point in the new year. And on behalf of all of us at McGill, please accept my best wishes for a happy, relaxing, and safe holiday season. Thank you.
Okay, thank you, Derek.
Thanks, Derek, for putting up with us.